Hello and welcome to this webinar. The title of today's webinar is Retinal Tracking, One Big Leap Towards True Confluent Repeatable Image-Guided Laser Treatments. My name is John Empson and I am a product specialist for Instinctive, who are the business partner for OD/OS and the Navilas laser platform in the UK and Ireland. I'm very happy to see so many people joining us online today. This webinar will last approximately 15 minutes and describe the paradigm shift in treatments performed with a fully digital laser system that tracks the retina. A comparison of retinal tracking to traditional single spot or pattern lasers will be made. It will also consider why retinal tracking is synonymous with safer and faster laser applications, and consider the concept of true confluent, even-fluence repeatable treatments as prerequisites for subthreshold treatment strategies. I am happy to welcome today's presenter, Dr. Eugene Ng. We are very proud that Dr. Eugene Ng is joining us today from the Institute of Eye Surgery, where he is medical director. The Institute of Eye Surgery is based at UPMC Whitfield Clinic in Waterford, Ireland. Eugene is a retina specialist in one of Ireland's largest private ophthalmic surgical practices. He completed his fellowship at the New Zealand National Eye Centre and has also spent time in operating rooms in the USA, the Netherlands, Hong Kong and Kenya. Eugene serves as a consultant to several ophthalmic device and pharmaceutical companies through his involvement in clinical trials. Eugene's short presentation will be followed by a Q&A session. To type in and send your questions, please use the chat window of the webinar application. We will answer as many questions as possible during the Q&A session. Any remaining questions not fully covered today will be answered offline after the webinar, so don't worry if your question has not been selected, nothing will be missed. But now, let's get started with the presentation.
So welcome everyone to this webinar and thank you for participating. Our topic of discussion today would be retina tracking and how I believe it's one big leap towards true confluent repeatable image-guided laser treatments. These are my financial disclosures, but I have no specific conflicts of interest pertaining specifically to this presentation. This is a survey from ASRS memberships. In spite of DRCR and NASH Protocol S and the Clarity study published in Lancet 2 years ago showing at least non-inferiority or superiority of ranibizumab and aflibercept respectively, only a small minority of us rely exclusively on anti-VEGF injections for young patients. We've come a long way in laser technology since the first xenon arc treatments in the 60s. This picture is fascinating to me because it reminds us that technologies improve, but we frequently have patients with lifelong medical needs. Here we see massive xenon arc burn size alongside non-pattern laser on an ultra-wide field image. The red arrows demarcate the faintly visible non-pattern laser, while the large blue arrows show the big burns that we see on xenon arc treatments. I'm going to use this session to discuss the concept of retinal tracking and how it has changed the way I think of laser delivery to the retina. Image-guided lasers have allowed refractive surgeons to treat faster and more accurately, so as retina surgeons, we are really behind the curve. The Navilas laser has allowed me to perform faster and more accurate treatments by tracking the retina. So here is the anatomy of a slit lamp laser compared to the retina tracking laser. Our traditional slit lamp laser consists of a light source provided by a slit lamp, an aiming beam, and laser light source that is shown through the slit lamp and reflected into the oculars, to which we use to see where we are going. In comparison, the anatomy of the retina tracking laser is totally different. It has a light source that is coherent. It has an aiming beam and a laser light source as well, but this image is projected into a camera that the Nebula system uses to acquire images for the computer. It is this computer then that generates treatment profiles and controls the laser spot positions. So this is me performing a treatment. I can look at the treatment plan on the screen and the patient simultaneously. I can now perform PRP and macular laser without a contact lens and use an infrared light source. So before the laser goes off, my patient sees nothing like an OCT. Does this look familiar? No oculus? What does this remind you of? Well, I've been fortunate enough to have worked with most versions of patient heads-up display, and I've little doubt that the brains in these machines will eventually change our subspecialty. I dreamt of a machine that would be better than I am, and I think we are a step closer. Please allow me to fly through the very obvious differences before spending more time on the last point, because I believe that true-confluent treatment with even-fluence is the defining difference between all slit lamp lasers and retinal tracking lasers. I'm going to show you a video of my own treatment from my first laser session. I would like to acknowledge the assistance of the Nebula team for recording these videos very late into the evenings with me. The bottom screen is the planning screen. The top screen is the live image. And the planning screen is generated from a still image. You can see from the top screen my tremor. But note how the laser follows the tremor and locks out the no-fly zone or no laser zone in spite of this tremor. Because this was my first case and for familiarity, I started with a contact lens. So I'm holding a contact lens in one hand and planning the laser spots with the other. Of course, it is possible to sit the patient back, plan the treatment with the still image, then reposition the patient. The retina spots, as you can see, are rapidly pre-planned and the laser locks onto its target. The second advantage of this system is that treatments through poor media is possible and far more comfortable for patients when laser is stopped firing. This is due to the coherent, non-visible infrared light source. You will see from the pictures here of a patient with proliferative diabetic retinopathy with asteroid hyalosis. From the pseudocolor ultra-wide field image on the left to the angiogram before laser and the post-laser autofluorescence showing good uptake even in the absence of a good field. All these videos that I'm going to show you are only cut and not sped up. The laser counter is at the top. And you can see how 100 PRP spots are applied in 15 seconds. Accuracy and speed is one of the advantages of this system. You can see as this treatment proceeds, the disc and the foveal exclusion zones are in place and tracked at all times. This is another video without a contact lens, showing you that the treatment is actually going on while the patient is blinking. You can see that the laser tracks in spite of the laser blinking. 100 macular shots, 15 seconds, And as you can see, the ocular fixation is more stable than possible with a human hand. We are using the patient's own ocular fixation instead of a contact lens held by our own hands. It uses infrared illumination, so unlike a slit lamp, the patient does not see any light, and I believe is far more comfortable. Having seen this treatment, would any surgeon want to match this machine? Look at how even these laser spots are. On the right was the treatment plan screen that you saw, and on the left, the autofluorescence after treatment. This brings me to the defining difference between all slit lamp lasers and retina track lasers. So please allow me to share one very important concept with you. Towards the end of my training, I would be able to tell which surgeon had performed the laser treatment. This means that laser surgery is as much an art as a science. Like rhythm strips from an EKG on the left, a non-pattern laser produces irregular burns, as you can see on the image on the upper right. A traditional slit lamp pattern laser produces irregular burns, and a track laser produces regular burns. While it probably doesn't matter much that laser spots are overlapping or there are patches of untreated retina for PRP treatments, but I would like to suggest that such treatment inaccuracies are critical for macular lasers. The untreated areas are circled in white, and the overlapping spots are circled in black. Even if you get a grid pattern, you can see that after treatment, we have patchy uptake of laser. This is a phenomenon that I call uneven fluence. Paula Schultz from Cologne very elegantly summarized the main publications for subthreshold treatments in this publication. You will notice that the CSR treatment parameters vary widely. The parameters are different for different disease types, and the list of DME doesn't end here. Unfortunately, all these studies are not comparable with each other because of the different parameters used for treatment. There are fewer studies for vein occlusion, but the same theme applies. And here are the pooled results for what it's worth from most of the studies. However, I do not believe that it is possible to enumerate art. I love sharing patients. These are the pre and post infrared images that I've shared with my colleagues who has performed subthreshold laser for a CSR patient who requires very fine acuity for work. I sent him for a micropulse treatment to London prior to us acquiring a retina tracking laser. Due to invisible treatment spots, it is not physically possible to evenly paint an area of retina. As a result of uneven fluence, some areas were overtreated, and I'm sure some areas were also undertreated. This is a CSR patient I treated with subfoveal subthreshold laser. Given that the system continuously tracks the retina, the treatment plan can be made based on any imaging modality where retinal markings are visible. In this case, I used fluorescein angiography to drive my treatment plan. This treatment plan can be saved and recalled at a later date, making retreatments of the exact same area and parameter possible. True-confluent treatment with even-fluence enables repeatability. You can see how it takes 20 seconds to zoom into 330 true-confluent spots, cover the foveal and perifoveal area. There were titration spots planned temporarily. You will note that the system treats alternating rows to prevent thermal crosstalk between spots. However, I would obviously like to caution colleagues when treating closer and closer to the fovea to ensure that the actual spots do not deliver a visible burn. It is bad science to tell you that subthreshold treatment works based on this one treatment. I certainly won't extol the benefits of subthreshold treatments for the reasons I've shared earlier, and I personally believe that the jury is still out. This is because unless we can perform clinically robust trials using a laser system that removes most of the surgical variables, we will not have strong scientific evidence for its efficacy. Only with true confluent treatment and even-fluence that is retreatable in exactly the same area are we finally able to scientifically study the results and effects of high-density subthreshold laser strategies without confounding certain factors. So in summary, unless we are able to effect treatment plans like these repeatably, the enabler for this technology being true confluent treatments with even-fluence that is repeatable and treatable in exactly the same areas, we do not have the prerequisite yet prior to this technology to evaluate high-density subthreshold laser strategies. So here are the differences between different laser technologies. We can prevent iatrogenic burns to the disc and fovea with patient or surgeon movement using the tracked and image-guided lasers. We can pre-plan treatments with tracked and image-guided lasers. We have an invisible light source which is coherent as part of the tracked and image-guided lasers. Both the pattern laser and the tracked image-guided lasers are supposed to provide fast treatment. I've just shown you how different or faster these treatments are compared to single patches of pattern laser. And I would also like to caution reports of pattern laser being less painful. I do not believe there are robust studies looking at pain, comparing them to the uptake of the laser and the fluence lasers, of the lasers comparing them to single spot lasers using imaging. For that reason, less painful may also be less effective. Tracked and image-guided lasers, I believe, is the only platform that allows us to provide true confluent, even-fluence, and repeatable treatments. With this, I would like to thank you all for listening and would welcome any questions you may have.
Thank you very much, Eugene, for this in-depth presentation. We will now move on to our question and answer session. Just a quick reminder to type in and send your questions. Please use the chat window of the webinar application. We will try to answer as many questions as possible. If your question is not answered today, we will do that offline after the meeting. Eugene, are you ready to answer the first question?
Yes, John, thank you.
Okay, our first question is asking, in which cases, situations, or indications are you actively using the microsecond pulsing mode? Eugene, did you hear the question?
Yes, I did, John. Thank you. So the commonest cases that we use these treatments for would be mainly patients who are less responsive to anti-VEGF treatments, namely DME and vein occlusions, when trying to extend or enhance the efficacy of intravitreal injections. And another very useful group of patients would be in treating chronic central serous retinopathy.
Okay, thank you. Next question, how do you evaluate the effects when treating in infrared mode?
So there is two options to either treat in color mode or to treat in infrared mode. The contrast of the image is slightly different on the infrared mode because it only involves image from one single narrow band of wavelength, and the contrast isn't quite the same as with the white light or color. Therefore, when evaluating a burn, bearing in mind that it takes time for the actual uptake of the laser as we naturally or traditionally know it, we need, when it comes to evaluating the uptake of laser on the infrared mode, we ought to wait a few seconds or even up to a minute for the full laser to take on the RPE. And there is a very clever way of taking a snapshot in color on the system where it allows you to actually compare the pre-laser and the post-laser image in the area of interest. And that can be toggled then between the pre and that is then toggled between the pre and the post treatment within that center of the laser spot.
Okay, thank you very much. I have another question here asking, from your experience, how can Navilas bring more efficiency to your daily workflow versus other pattern lasers?
So mainly in two ways. One of the ways I've described would have been that it provides faster treatment and that I'm able to place far more spots in a shorter period of time. But also there is the facility to pre-plan the spots in clinic using images that are acquired in the diagnostic suite. So there is a facility to import OCT images, ICG images, and fluorescein angiogram images, which then is used to overlay on the color images that is being obtained by the Navilas system. You can pre-plan the areas of interest ahead of time while seeing the patients in clinic, so that you don't need to refresh yourself at the time of treating the patients if you treat patients as two separate visits, clinic visits.
Okay, thank you. Another question here. What makes a PRP efficient, and what do you need to consider when using systems that reduce the pain?
So that's a very important point, John. The easiest way to achieve painless treatment, which is definitely not what we want to do, is to actually undertreat the patient. And that is why there's at least one study showing that one such slit lamp pattern laser is less effective. However, it is possible to actually minimize patient discomfort and still maintain efficacy by using fast, accurate laser systems and ensuring even-fluence. So with this tracking system, I'm actually happy to trade off some comfort for completing an entire PRP session in one single sitting, as long as the patient is under sufficient anti-VEGF or steroid cover to prevent worsening of macular edema.
Okay, thank you again. I've got another question. We're running out of time, but we'll go for this question. For anyone cautious of the learning curve with this new technology, can you give some more information about how long it took for you to feel comfortable capturing images and doing your treatment planning digitally?
Sure. So from a practical perspective, it is actually quite intuitive if the treatment plan is made in the clinic, and that makes it a lot easier when you're actually treating the patients because you have the patient's angiogram, OCT, or ICG in front of you where you have imported. That helps with the learning curve in that you already understand and know the case of the patient before you actually start the treatment. Another useful tip would be also to use the infrared light between the flashes of taking color images or before turning the color images on, because while the contact lens, if you use a contact lens that's on the eye to stabilize the eye for your early cases, the infrared is actually very comfortable because patient isn't blinded by a bright light, which you normally would have to undergo that learning curve when using a slit lamp laser. But when you actually view the retina with infrared, the patient doesn't see anything. It is also very intuitive for retinal surgeons who use a heads-up 3D display because you're already operating without an oculus. And in some ways, this is similar because you're actually looking at the screen instead of looking down the oculus. So I think those are the probably top 3 tips from me when converting from a traditional slit lamp laser to a Navilar system.
Okay, thank you. We are now running out of time, but we will answer all remaining questions offline. So, thank you once again, Eugene, for this interesting presentation and discussion. I enjoyed following the webinar today and hope our audience feels the same. We will inform everyone when the on-demand version of this webinar will be available. In the meantime, if you are interested in more clinical experiences and webinars with navigated lasers, please visit our website forum at www.od-os.com/experts. Thank you very much for your attendance, and I hope to see you soon.
Thank you, John.